opportunity to close off the e-consult without the need for a secondary contact in some cases. The other thing is the clinical safety we've embedded into the platform. So every online consultation provider will ask the patient to confirm upfront that their symptom isn't an emergency, and we do that as well. But we've taken it a step further by embedding red flag questions throughout the question set. So if a patient says it's not an emergency, but then continues to deposit symptoms we believe is unsafe for the patient and for you to send to the practice, we stop them and we give them appropriate guidance on what to do next. E-consults, once completed, will be sent to your practice from September. At the moment, it's currently being sent into your clinical system. From September, it will be sent into our smart inbox, which then allows you to work and triage e-consult very efficiently. So the e-consults, when they come through, will be named. So you could get admin e-consult, or you could get headache, mental health, and so on. On the point of mental health, we've got integrated scoring embedded into the platform as well. So if a patient were to present, we get them to complete the GAD-7 and PHQ-9. Just trying to think if I've forgotten anything.
I'll just jump in. I think just reverting back on the point of clinical safety. I think the reason we think that element is particularly the red flag on the patient side is really, really important. It's because the patient's presentation into you is static data. That's their presentation at that moment in time, and it's accurate at that moment in time. What we can't countenance is potential escalation of symptoms. So some symptoms may in their nature be self-limiting, we acknowledge that, but we can't actually understand whether those symptoms will be self-limiting or would potentially escalate. What we try and do is mitigate the risk of those escalating, as well as the urgent symptoms for those escalating symptoms, if we feel that the timeline for response is inappropriate for that patient's presentation. So it may mean that they don't need an emergency response. They may not need an A&E or 999 response, but we've looked at their presentation and we feel that actually there was significant risk of escalation, stop the consultation, because actually the reality is that if the practice responds next day, we may be looking at a completely different type of question sets. So we do ask the patient to go and get some, what we consider synchronous contact, either with the practice or with 111, to mitigate any of those risks. And the important element here is none of that information is passed through to practice. Historically, we've had extended dialogue with the medical defence unions, and the presumption has always been as soon as that information is passed through to the practice owns some of the clinical responsibility for that patient. So what we say is that red flag stops the patient and the owner sits completely with the patient's next steps. We don't pass that risk back onto practice. And we do that very deliberately because patient may submit at 10 o'clock in the evening. You may not look at it until first thing in the morning. They may submit on Friday night. You may not see it until a Monday. So we have to consider all of those potential patterns of usage from patients before we start saying, is it appropriate for you as a patient to be online consulting for your particular symptoms? And that's why we were trying to make sure anything that's passed through to you is clinically appropriate for that particular channel.
Does anyone have any questions following that?
I should also add that we've got Tom Bullier on the call. Tom leads our team of transformation managers. They will help practices implement e-consult in an efficient and safe way. So if you have any questions around how you can implement e-consult and what support you get, we'll be very happy to take that as well.
So you mentioned about the sort of the risk of patients completing sort of close to a weekend. I know the answer to this one because we've gone through the full procurement. But do you have any sort of way to protect those sort of situations? So do you have any sort of switching off functionality?
Yeah, so we've got two forms of sort of what we call demand management function. You've got the sort of ad hoc, as in today I think I've had too much demand, I want to snooze my consultation feature. Now what that means is that we don't switch off the entire platform. So patients who hit the platform at that point can still interact with the self-help and signposting options, but the ability to send an e-consult request into their practice is snoozed until the following working day. So that allows the practice to react to their demand on the day. The other option is planned demand management features, and these really fall into two buckets. There's a timed feature, so you can time the window of your consultations, which may mean that you decide that I want to receive consultations in hours, Monday to Friday. It may mean that you only want to receive consultations Monday through to Friday, but with 24/7 access. It may mean that you want to receive it 7 days a week. You can choose how you want to customize your opening and close hours which are most appropriate to use a practice. What we do tend to find is practices that are closer to a total triage type of model do tend to leave their service open longer, and practices that tend to use a more mixed economy approach to the clinic tend to use the features a lot more. So there's that time feature. The other feature is a capped feature, so we can cap consultation volumes. So you can say, today I can accept 50. Once you hit 50, we close the consultation engine and it's closed for the rest of the day until the following working day. So there's really 3 ways of you managing your demand in. And it's really going to be down to the practice to consider how they want to use those features and whether they want to use those features as static features or they want to use them to react to circumstances. It could be that, by way of an example, that you typically leave your platform open 24/7, but over summer you've got several clinicians on holiday and you don't believe you've got an adequate level of resource to manage consultations open on a 24/7 basis, therefore you may curtail your availability. So you could use it in that sort of guise, that reacting to demand, or you could just decide that I only want to deal with traffic Monday to Friday in hours. There's a whole array of configurability options here in regards to patient pathways through. In all instances, those configurations are applicable only to the consultation engine. So patients who hit the platform when the consultation engine is closed can always still continue to use any self-help or signposting options that are available.
Does anyone have any questions following that? Okay, so you mentioned about the smart inbox. So is there anywhere people can sort of go online to see sort of how that's going to look as a sort of concept, or do you have any sort of any materials that can be distributed?
We can certainly send through some sort of links to our website, as well as mail shots, etc. have gone out. I believe in the last session we did, I did a live demo of the smart inbox, so that recording would have a good chunk of that recording would show the interaction between the patient front end and the smart inbox as the back ends. So a lot of that is accessible to everybody, and I'm happy to send you through any other sort of links and documentation that you can disseminate across the team or across the group.
There was also a webinar held on the smart inbox from our product team, which is available on demand as well, so we could share that link as well.
Yeah, that's no problem. We'll link that in the sort of any communications that gets sent out. So in terms of the red flag functionality, sorry, just to sort of bounce to and fro, can a patient, if they've completed 2 questions and suddenly they get given the red flag functionality, can they sort of jump back and change their responses, or is it a case of stop right now, you know, this is done?
No, there is a gate. There is a gate. So what happens is if the patient triggers red flag, a warning pops up. So the first warning before they end their consultation advises a redirection is the most appropriate channel for them. But if the patient feels like either they're not answered correctly, or maybe they misunderstood the question, they want to reread it, there's an option to go back and they can amend their response if they choose to do so. But if they choose to continue, when they continue at that point, they're effectively closing the consultation. So the next step would be, I accept the advice, close the consultation, can't go back anymore. So there's one gate for the patient to consider whether they've made the right decision in regards to their response, or they wish to seek further information. Sorry to interject, Tita, I thought it might be useful. Tom, you're on the call. Just to kind of give context, we're very aware of what happened largely through the pandemic, where there was a big drive to switch on online consultation services nationally. But there was really a lack of capacity to really think about how do we embed the change to drive true value. And I know Tom and his team have been working very, very hard to think about what does that value proposition look like. So actually the end user is confident and capable to use the platform to drive value. So Tom, could you just spend 2 or 3 minutes to kind of say, kind of just articulate verbally what sort of process a practice would go through from an onboarding point of view?
Yeah, sure. So the way that we've delivered and really taken a backseat, as Aman says, and really looked at how we onboard our practices is we've taken a kind of a different phased approach. So as we know, there are a few aspects technically that are required, and Faye's also joined our call, which is our operations manager, who kind of help lead the technical deployment, and that's getting you set up from, you know, getting the banner on your website and making sure that you've got everything configured to be able to switch the platform on from a technical perspective. So that's kind of like our phase one. And then what we've done is created a series of webinars which will always be available on demand as well, to be able to watch in your own time if you can't make them live, and they'll have our team on from a Q&A perspective. And it's all around the fundamentals of setting up, whether that's, you know, talking about marketing and how you utilize marketing. Now, as Aman said, a lot of practices had to just switch on online consultation very quickly. So patients may have got into some maybe bad habits, and how we utilize marketing to help engagement and education is really important, as well as spreading the message of online consultation. So we talk about those kind of factors, as well as looking at how you manage your workflow within your teams and how you best manage with different members of your team, whether that's admin, secretarial, and clinical, whether you have triage models and so on. So we have our kind of triage modules that we also run, as well as training modules. And what do we mean by training modules are actually, how do you do this? How do you use our toolbar to send a text message or start a video consultation? How do you actually use our long-term condition templates to benefit you within a practice, within your workflow? So those are the kind of the three phases. We talk about that technical deployment, the transformation and change management that's required, and how you can use different skills, methods, and technologies to support getting to your end goal as a practice, which is really important. And then there's the training to use our features and our functionalities. And as both Stella and Aman have mentioned, that will start including our smart inbox later on in the year, and how to use that, and we'll be able to support that with different workflows and different trainings based on your model, really. So at the moment, those are delivered at scale, but our transformation team are always available for questions or additional sessions if there's particular challenges that you as a practice are facing. Obviously, we've been doing this for quite a long time and probably faced quite a few different challenges along the way, and how we solve them or work together. Some of it may be around education, some of it may be around workflow, some of it may be around training, but it's then how we work together and pull it all together for your practice.
Any questions on that? Okay. In terms of user experience, sort of the user interface, what's the average sort of duration of time, if you know that off the top of your head? Do you know the average user sort of time from the point at which they start the online consultation to when it's submitted? Is there?
Yeah, happy to jump into that. So the current average journey time is 11 minutes 32 seconds. We acknowledge that there has often been a little bit of pushback from some patients that they feel our templates are too long. We're always we're mindful of that, and actually we've reduced that average journey time by 16% over the last 6 months, and it's a standing agenda for our product team to continue working on the platform to think about how do they reduce the journey time. But the important measure here is it's not just reduction of journey time. It's easier to reduce the journey time by removing questions and removing data. But we're also very mindful of that we've got to have an adequate barrier to entry. So what we don't want is something that's so easy to get through that you're getting high volume, low quality data, which is then all it's doing is facilitating secondary contacts. And also it makes it so easy to submit that patients start submitting for rudimentary complaints where they otherwise potentially wouldn't have even considered submitting. We want patients to invest some time and energy in this because it's the start of their consultation with you. But at the same time, we want the data that comes through to you to be robust, structured, and something that you can manage potentially completely remotely. So you're not facilitating secondary contacts. And that for us has always been, there's a significant trade-off here. And if we simply just remove questions to facilitate shorter patient journey times, we're actually not solving the problem at the practice end. We're probably exacerbating the problem at the practice end. Now, one of the things we're launching very imminently around this, and some of this work is already launched, is the customization around QOF templates. So whether you wish to ask the QOF-related questions on every consultation, and that you as a practice can decide whether you want to switch that functionality off completely, i.e. not harness the QOF data, or ask it periodically. So it may be, for example, you may choose that I don't want to ask it if a patient's submitted a consultation in the last 6 weeks. I don't want those questions to present again because I've got reasonably recent data proportionate to the smoking and the alcohol status. So that would be down to a local flavour. The practice can configure that to whichever timeline they deem most appropriate for them. The advantage will also be that once we've got the smart inbox live with fully coded data, static codes in, the QOF data will code directly back into the clinical system. So there's no manual work for the practice to code that data back in.
In terms of that, so the QOF functionality there, do you know what the timeline is for that?
Okay, so the smart inbox with full integration is due for end of September, early October. So, and the QOF element should, at this moment in time, be in line with that because it's part of the same integration. So we're looking at almost exactly the same sort of timeline.
In terms of sort of patient satisfaction, do you run any sort of questions sort of following the online consultation? Is that something that's reported back to the practice?
Yes, we do. So we after patients can opt into a one-time survey, and at the moment about 15% of patients opt into those surveys, or sorry, respond to those surveys once they've opted in, and we send a survey link to the patient 7 days after the submission of their Econsult. Now, the reason we do it 7 days is because we want to harness the entire patient experience, because we acknowledge that the experience is not just with the platform, it's also with how the practice utilizes the platform. So we want to understand what the developmental areas are, not just for us from a product perspective, but also from our users from a delivery perspective. And it could often be that we could see that patient's experience on Econsult is very strong, but actually practices are struggling to operationalize their workflow. So patients aren't being contacted within adequate timelines, or they're getting poor outcomes. We want to try and give that encompassing data set so actually practices can determine actually what can we do to improve our workflows and our standard operating procedures to improve the patient experience and our delivery. Now that data is sent back to both practice and project leads on a monthly basis in an aggregated, anonymized fashion. And then as our account management team and our operations team pick up the practices, we try and use that data as a leading indicator for supporting developmental change. And we use the product side of it internally as product to drive our product development. But Tom will also look at a lot of the back-end patient practice-facing data to understand where do we think we've got development opportunities with practices, and how do we develop more training modules to support practices to improve their workflows. So we use that data as much as actually, in fairness, a lot of the practices and yourself as project leads will use that data.
Great, thank you. Last chance, does anyone have any sort of questions following any of the queries that have been raised today, or any queries they've sort of previously had within their practice? Because I'm mindful that the deadline, the imposed deadline for sort of choosing your selected tool is coming up. So we're quite keen to make sure everyone has all the information they need.
So I'm sure they can type the questions as well. We haven't said that before.
No,
you can catch us after this meeting. There's a link that was sent out. So if you don't want to speak in public, you can reach us directly.
And guys, I appreciate this can be a strange scenario for a lot of practices, particularly from a decision-making perspective. And so I suppose instead of just focusing on questions, I like to focus on fears. What are your fears and your concerns around Econsult? And I'd love to be in a position to try and address those. Don't have to do those now. If you feel this is not the greatest forum, please contact us directly. We can pick those up on a one-to-one basis. But acknowledge that actually, and I've been in the business 7 years, and kind of to give context, that's 80 practices when I joined to sort of 3,200 as of yesterday. So I've seen a lot of growth, but I've also seen a lot of the fears and the trepidations that practices face in evolving circumstances. In that time, we've gone from, central funding around online consultation, mass rollout, pandemic, total triage, lots of product development, lots of competitors. So happy to address some of the fears and concerns, because I think that's really where I think we can help. We can lend our experience to try and allay some of those or support you through some of those. I did see there was one question that came through in the chat. So from Teresa, can functionality configured for admin type queries exclude clinical if this was a route for practices chose? So I presume, Teresa, I'm just reading between the lines. I presume you're asking whether you can switch off the clinical templates and only leave on the administration templates. At the moment. Okay, so David, I'll come back to your question in a second. So Teresa, the simple answer is no. And the reason the answer is no is because ultimately what patients will end up doing is they'll end up using the admin templates for clinical queries that doesn't have the same safety embedded, the right question sets and all the red flags. So actually increase the risk profile. And we've seen this already because I can say from experience, 5 years ago, we had a practice ask exactly the same question. We did an A/B trial on this. And actually, we found out about 30% of all the admin templates came through were just forms of clinical presentation. And patients were just bypassing the fact that it was admin just as a routine to talk to the practices. So we'd rather give the patients the options around clinical. And actually, in regards to your ability to leave functionality on and off using the demand management features, we'd rather you control it using that, because that's something that is allowing appropriate patient access, but also closing it down when you don't have the right level of capacity. So I'm hoping that answers your question. David, cheap one, why should we choose you over Acronyx? The simple answer is we're better. No, we are, but what Acronyx has done very, very well. Thank you, David. See your face now. Makes it. I'm talking to the person asking the question. What Acronyx has done very well is Acronyx is a great communication tool. Where we've started from is we are a triage tool. We've always positioned ourselves as a triage tool. What we're not trying to do is capture unstructured, undifferentiated data, present it to you, and then ask you to interpret it. Because typically that interpretation will force you to make secondary contacts with the patient to elicit more information to help you adequately manage the encounter. What we are always aiming to do is give you a robust history. So in 4 out of 10 cases, potentially you can manage this completely remotely without the requirement of a secondary contact, or the secondary contact purely being outcome. So it's giving you a better data set to work with. It's also giving us more robust features in regards to safety. The reality is every single online consultation tool from a clinical risk perspective does exactly the same thing. As soon as it lands with you, the clinical risk is with you. Now, what we try and do is we remove the stuff that we believe is inappropriate for that journey. Acronyx don't. They pass everything through, and then your workflows have to be slick enough to pick up the stuff that is urgent and has to be picked up really, really quickly. Because we're always looking at two facets of patients. Patients, everybody has these, as Stella articulated earlier on, everybody has the self-declaration symptom questions up front. And that's okay. But what if a patient doesn't understand that the symptoms are clinically significant? You know, an example I often use is we've got a red flag question around numbness around your bottom if you've got lower back pain. Now, you as a clinician may pick that up as, lower spinal cord or minor, but a patient may just feel it's musculoskeletal pain, and maybe they just pulled a muscle in the lower back. Now, we don't know that it's one or the other. So we will red flag that patient, ask the patient to contact the practice and get a more immediate response, because actually we know that's a risky symptom. In the Acronyx example, they would push all of that through. You would have to make sure your workflows pick that up quickly enough to mitigate risk to the patient. And at that point, all of the risk is sitting with you. So I hope that answers the question, David. Anything else, guys?
I suppose, as mentioned, there are sort of ways to communicate with Econsult if you don't feel comfortable using this channel. But if no one else has any queries or questions, then thank you very much for your attendance, guys. That was greatly appreciated.
No problem. What I'll do is I'll just put our contact details back in the chat as well, just in case anybody does want to send us an email.